Hello and welcome to our webinar, Billing and Coding for Concussion Care. I'm going to go over a few opening items, then I'll introduce our presenter and we'll get started with the course. The statements and opinions contained in this program are solely those of the presenter. Treatment options and tools presented are some of many that are available. All individuals in control of content disclose no relevant financial relationships, and other continuing education disclosures can be found in your course information document. Learn the must-know tips to get the best reimbursement rate for your concussion care services. This course will review commonly reimbursed CPT codes for concussion management and how to document your services to improve your reimbursement rates. At the end of the course, attendees should be able to identify commonly used CPT codes and the rationale for using each code, review documentation practices that help a healthcare provider get the best possible reimbursement rate, and review case studies detailing concussion care services and how to bill for each service. And our presenter is Dr. Jim Gerke, who serves as the Chief Operating Officer at Impact Applications. Jim oversees all operations for Impact Applications. Prior to joining Impact Applications, Jim was the Vice President of Sales and Marketing for PAR Inc., Psychological Assessment Resources, a leading publisher of psychological assessment instruments, software, and other related materials. He served as an adjunct professor in the Department of Education at Trinity University, and his current research has been published in 15 peer-reviewed scientific journals and has made over 200 presentations at state, regional, and national meetings. Jim has served in advisory, technical, and review roles for almost 20 industry-related boards and professional journals. And Jim currently resides in Tampa, Florida. Jim, thank you so much for being here and for talking with us about billing and coding for concussion care.
Thanks, Hannah. So an overview for today's course is that we're going to examine a bit about credentialing and then coding and then some of the specific CPT codes relevant to the procedures that we're going to present later on in some of the case studies. I know that all of you are interested in reimbursement, so we're going to focus a bit on that. We're also going to offer a description of a typical clinical structure, the number of people who are involved in case flow and et cetera there. We'll also discuss some of the documentation requirements, and then finally review the case examples as it relates to both baseline and post-injury testing. Okay, in terms of credentialing, there's some basic issues that you have to consider. One is private practice versus a public facility. The others are things like, are you a medical provider versus a mental health provider, and does the payer treat those differently? Obviously, you're going to want to understand what the credentialing requirements are for the largest payers in your region. You probably already know who they are because of the insurance that's being presented by your patient population. It's a good thing to try to get onto insurance panels. Some of the panels have you listed just as a psychologist or a health provider. Others separate out psychologists versus neuropsychologists. I have recently been running into more pre-authorization requests by insurers, meaning that more and more insurers are wanting to understand the nature of the referral and then to authorize the service before you actually provide it and then bill it. Steps for working with insurance providers. Typically, a patient is referred for concussion evaluation and treatment without a specific diagnosis. So, there are two ways, I guess, to consider this. One is you already have a diagnosis and the patient comes to see you as a follow-up, different kind of case versus the patient comes to you with a suspected concussion but not a specific diagnosis. If the patient's insurer is a large percentage of your patient volume, it does make sense for you to reach out and take the time to get agreements in place with them for treating that type of patient. How do you do that? When you're working with insurers, you want to make sure basically that they cover the code set that you're going to use. And again, we'll review the typical code sets a little bit later. You want to understand obviously what they're going to reimburse you for. and the reimbursements by code. Do they cover the codes for a diagnosis of concussion? So, a TBI code, neuropsychological testing, are ones that you will typically use, and do they reimburse for services if the diagnosis is concussion? If the answer to all those questions is no, you still don't have to give up. There is a course of action you can take. And that is, you can contact the medical payer. Typically, provider relations is where you would start, or a medical provider line provided on the back of the insurance card for the individual. You may have to go back and kind of review everything with the provider relations person so they can understand the specific context of what you're asking them. You will want to negotiate with the insurer if at all possible. And in many cases, because this is such a specialized field, you will have success. What does success look like? Success can be that the patient is extended out of network medical benefits for your services. You can also be assigned in network medical status for certain specific procedures, or in the best case, you can actually get admitted to the panel for the insurer. If the insurance provider refuses to offer you a solution, they just don't even want to talk about, the service and adding a new provider in the area, then here's some information you can relay to the patient. That they didn't offer an in-network solution, and they didn't offer an out-of-network solution. So the patient will want to discuss that with their insurer, but in the short term, you're going to have to address, if the patient wants you to see them still, how you're going to get reimbursed for the specific services that you're going to be providing. Much of the talk today is going to focus on CPT codes, but I also wanted to introduce here the concept of ICD codes. Some insurers will use ICD codes, and ICD-10 has updated concussion and concussion specific codes, either with or without loss of consciousness. All right, let's look at defining the specifics of what we're going to be doing, and that's neuropsychological testing. Neuropsychological testing is performed by a professional with training and expertise in the types of assessments being requested. The test may be administered or scored by a technician, but it is always under the responsibility and the guidance of a neuropsych trained individual. Testing evaluation services. So there's a difference between testing and evaluation. Testing is the act of completing a test. Evaluation is both the testing and then the integration of the data with some interpretation. Interpretation or report writing must always be done by a licensed healthcare professional, like a licensed psychologist or a licensed physician. Face-to-face contact with the patient while testing is important. That means that someone has to go in, set up the testing for the patient, make sure that the patient has access to the person should they encounter any problem during the testing. Computerized testing, which is the hallmark of concussion evaluation and diagnosis. Computerized neurocognitive testing has been found to be useful for identifying athletes who are concussed within a week period or longer after a concussion. The issue of baseline testing is generally debated in the field. There has been a lot more research recently to support the notion that baseline testing, particularly for atypical students, students who are either very high performers or low performers or have a special ed diagnosis, is critical. And while it's not mandated, interpreting the individual's performance against their previous performance is preferable to comparing them to normative data. Clinicians form diagnosis, not the software, not the tests. So it is always up to the clinician to formulate the diagnosis. All clinicians should be cautious in interpreting test results in isolation. Um, Most professionals understand the need for multifactorial and multidimensional data before arriving at a diagnosis. When managing concussed athletes, there's no single tool, including the impact test, that should be used as a standalone measure. And the reason for that is that no two concussions are alike. And so what we see here is that one concussion may manifest itself with more cognitive type issues, while another may have more balance issues or vestibular issues or vision issues. So it's always good to include a variety of different tools in order to come to the appropriate diagnosis. We do know that, in referring to the baseline testing, that it is stable across a period of time. So even if your athlete gets injured 6, 8, 10 months after the baseline test, it still can provide useful information for you about that athlete's pre-injury performance, and for you to evaluate when that athlete is back to that pre-injury status. Impact is a tool, has been found to be helpful in a variety of different contexts related to concussion evaluation. Most recently, research findings have extended the use to treatment trajectories. When you gather impact data, understand that it's not just for the purpose of determining whether or not the person has a concussion, but also to help guide further treatment recommendations, because, as I said, no two concussions are alike. All right, let's look at the coverage rationale now in terms of a traumatic brain injury. Why is it covered? Well, traumatic brain injury is defined as a bump, blow, or jolt to the head that disrupts the normal function of the brain. So, it is, despite what many people over the years have thought, concussion is a traumatic brain injury. Baseline testing in athletes or other individuals does not alter the risk for concussion. So, because you've been baseline tested, that doesn't add a protective layer, meaning that you are less likely to get a concussion. Simply, baseline testing is useful for the healthcare provider to look at post-injury performance as it relates to the person's status before the injury. Computerized neuropsych testing is the centerpiece of concussion evaluations. That's been supported in the most recent concussion in sports consensus statement that came out of Berlin at the end of 2017. Scans such as x-rays, MRIs, CT scans, generally not very helpful in informing a concussion diagnosis. And that's because in almost every case, the scans will show up as normal, even though the person may be concussed, because concussion produces a neurochemical change in the brain versus a large structural change. Computerized neuropsych testing, as I said, should be used in combination with other types of observational data, patient report, etc., to form a complete picture of the patient. So, most of you are familiar with the fact that in 2019 there were changes to the psychology CPT codes. I'll review the common codes that you've used in the past and kind of give you a little bit of a crosswalk as to what they are now. So 96116 neurobehavioral status exam has been broken into two codes. 96116 is the first hour of a neurobehavioral status exam, and then 96121 provides each additional hour of service. 96118 is now four codes, and that is 96132 for the first hour and 96133 for every additional hour. Important here is to understand that what goes on in that hour is everything from test selection to clinical decision making, test administration, and test interpretation. So don't forget to include all of those activities into the time allocated for the activity, and in most cases that will easily get to be an hour, and in some cases it certainly can go over an hour. 96118 also has then 96136 and 96137, which are first 30 minutes and then an additional 30 minutes. And again, it also includes time spent scoring and interpreting the tests. 96119, which is evaluation services by a professional, is now four codes, which is 96132 for the first hour, 96133 for the additional hour, and then again 96138 and 96139. So just as I mentioned before, it's whether it's an hour service or 30 minutes worth of service. 96120 is the one who's seen the biggest change in a sense, because it is now 96146, and it is simply the testing element, that is a psychological or neuropsychological test administration with a single automated instrument via an electronic platform with automated results only. So this is none of the selection of the test, none of the interpretation of the test in terms of feedback, and no treatment planning, simply the test, administration, and scoring. So that's been a big change. Most of you are familiar with the fact that these codes oftentimes get paired up with E&M codes, which are evaluation and management of the patient codes, through what's called a modifier. Billing for an E&M service requires the selection of a CPT code that best represents what you did. So it's based upon patient type, new versus established, the setting of the service, which is an office or other outpatient setting, hospital, inpatient, emergency department, etc., and then the level of the evaluation, and that's how extensive was the history, how extensive was the exam, and then how complicated was the medical decision making around that. These next two charts kind of break down for you how to decide in a new patient versus an established patient which of the five levels of CPT code you should select in order to get the right E&M. In almost every case, you're going to end up in 99202 or 99203. In more complicated cases, it's going to be in 99204 or 99205. With a new patient visit, again, it's not uncommon to have a very complicated case, but again, in almost every case, you're looking at a 99203, 99204, somewhere in there. Same with the established patient. Again, this is the time and the complexity of the decision process, along with the presenting problems, will determine which of the codes that you choose. With E&M codes, there are generally two types of modifiers. One is 25 and one is 59. And the question is, what's the difference and when should I use 25 versus 59? I can say in most cases, the 25 is the more commonly used. Some insurers are going to request you use a 59, but in more cases than not, it's going to be a 25. So a 25 modifier eligible service is defined as a significant, separately identifiable management and evaluation service by the same physician on the same day of the procedure or other service. You're supposed to use this modifier on that day of service that the E&M was performed, and the patient's condition required a separate and independent service above what you would typically do in an E&M visit. So simply put, you should only ever use modifier 25 in conjunction with an E&M code. On the other hand, 59 is a distinct procedural service, and it's used to indicate that you performed a distinct and separate service from all other services. Typically, you'd use that to justify a pair of billing codes that would not ordinarily be built together, which is why I said earlier that you're more often than not going to use a 25 versus a 59 modifier. So everybody cares about their reimbursement because it's how you provide the services you provide and keep your doors open for business. Reimbursement, to say the least, is a fickle thing, and often it's without a consistent pattern across or even within an insurer. I've heard of a provider doing the same service with patients, one time getting a payment and another time being rejected, and there certainly is a lot of variation across plans. So, for example, some Blue Cross Blue Shield plans allow for neuropsych testing as long as there is a medical diagnosis used. Others require a mental health diagnosis. My advice to you is, because there's so many factors that affect how this gets paid and what it gets level it gets paid at, to develop kind of a routine with the payers that you routinely work with to figure out what it is they want to see in your notes and in the supporting documentation that will support the best payment you can expect. It may be some trial and error on your part, and it may require you to go back to payer relations to figure out why something was denied or paid at a lower level. But once you've got kind of a consistent pattern and the insurer is used to seeing that, makes things go much more smoothly. In almost every case, most carriers will cover neuropsych testing for sports and non-sports concussion, as long as you kind of play by their rules. If you're an MD or a DO, any medical person, there's also some alternative codes you can look at. The 96 codes for time-based testing, not 101, 102, 103, and then there's psychiatric or farm management codes you can look at. Again, this applies only to physicians, so you probably, if you are a medical doctor an osteopath, you're more familiar with those and know when they're appropriate to be used. In terms of approximate reimbursements, and these are broad ranges because you're, again, dealing with insurers that, private versus public and different geographic regions, etc. 96116, we're seeing about $97, 97.31. The not 121 add-on 96121 is an additional $83.61. 96132, anywhere from low 200s to 286.50. 96133 is 101, and 96136 78, with the add-on half hours at about the same. 138 and 139 are 38.92, and that's because it's testing done by a technician and not a neuropsych trained individual, meaning not an MD, PhD type person. Now, I mentioned earlier 96146 is the one that has the largest change, and this is the single test that is administered via computer and interpretation provided by the computer. Reimbursement there is in the $2 to $3 range. So, again, if you can avoid that, that's probably better. So, okay. You can see in this table that it is based on RVUs, the relative value of the services provided. I'm not going to go through all those, just understand that that's how the reimbursements were decided. So in terms of clinic structure, you can see here that patient volume dictates billing. You have to be mindful of how your clinical practices are perceived if you were to go through an audit, meaning you should make sure that there is sufficient face time allocated to the patients for what you're billing. I mean, if you were to bill 40 or 50 patients a day for concussion testing, that is going to stand out. So typical patient volume is 13 to 15 patients a day, with an hour to an hour and 15 minutes, and that includes everything from the intake to the evaluation to the testing to the follow-up. So just keep that in mind when you look at how you're billing your services. You can also decide to do additional paper and pencil testing. if you so chose. It's becoming less and less frequent now because of the time and personnel intensity of it, but it is still done in many clinics. All right, let's get to a couple of the case examples. First is a 42-year-old male. This is case one. 42-year-old male who stepped out of a portable building onto broken stairs, hit his head, no loss of consciousness. He went to the emergency center or urgent care center, reported headaches, light sensitivity, and some balance issues. He didn't have any significant medical history and no significant family history. So he was seen. It was a history and review of systems, which took about 10 minutes, cranial nerve evaluation, which took about 5, impact testing for 25 minutes, and then also was administered the VOMs and a BES. That took a total of about 60 minutes. His scores came up such that it was abnormal for the VOMs, and the impact scores were low relative to normative data. In this case, there was no baseline data, so his scores were compared to the normative data. He also, in the BES, demonstrated difficulty standing in a single leg stand, suggesting that there may be some balance problem along with some of the vestibular and cognitive stuff. So, treatment for this was recommended that he start a vestibular rehab program at home. And there was some cognitive therapy that was recommended for ongoing memory issues. He was provided a graduated activity plan for returning to work, which was, limited basis, and then was recommended that he come back in 2 weeks for follow-up. So this was billed at a 99202, which is about a 20-minute E&M with a 25 modifier, 1 hour of neuropsych testing, and the reimbursement for that was $205 for the 99202 and $286.50 for the neuropsych testing for an hour. The insurer in this case was Cigna, and the provider was a medical doctor, board certified in sports medicine and family medicine. Okay, case two, 43-year-old female. This was her third evaluation at a concussion clinic. She was originally rear-ended by a vehicle that hit her from behind, and she hit her head on the steering wheel. So what happened was hit her head on the steering wheel and then came back and slammed it back into the headrest, coup contra coup movement of the head. So she was transported to the ER, and from the ER she was then referred to a concussion clinic after she was stabilized. In the ER she was observed slurring her words. She reported being very sleepy, extreme fatigue, with piercing headaches. She also had no significant medical history and no family history of significance. In her review, in this again being the third time she was being seen at the clinic, there was 5 minutes for a review of history and systems, 5 minutes for cranial nerve, 25 minutes for impact, 10 minutes for VOMs, 10 minutes for BES. And so her VOMs was abnormal, her impact scores were very low, and her BES was abnormal for difficulty standing on soft surfaces. So in this case, a level 1 E&M was billed because it was a repeat patient. She was also billed 96136 for a 30-minute neuropsych evaluation. Reimbursement under 99201 and 96136 was $105 and $78 respectively. The insurance was Aetna, and this again was provided by a medical doctor with board certification in physical medicine and rehabilitation. Lastly was a 14-year-old female who lost her balance during gym class. She struck her head on the floor. She saw a school nurse who recommended she visit a concussion clinic. And when she got to the concussion clinic, the signs and symptoms she reported were nausea, dizziness, light sensitivity, and trouble focusing. She did have a family history that was significant for bipolar depression and cardiovascular issues. In total, her initial evaluation at the concussion clinic was 60 minutes. Again, 10 minutes for history and review of systems, 5 minutes for cranial nerves, 25 minutes for impact, 10 for VOMs and BESS. Very low VOM score, very low impact score, and difficulty with the BESS. So from one thing that stood out with her was her symptom score was very high. We did have a baseline on her where her symptom score was 2, and in this case it was 24. But all of her composites were significantly below where her baseline score was. In this case, we build a 99204, which is a level 4 E&M because of the complexity, 96132 for 60 minutes of neuropsych, and then a 96133 for an additional hour of neuropsych evaluation. We recovered on this one, on the 99204, 205, and then 96132 was 133.70, and 96133 was 101. And this was United Healthcare. And the provider was, there were actually two providers. One was an MD, board certified in sports medicine, and then there was also a PhD clinical neuropsychologist involved. Okay, those are the cases. Again, they're typical cases that you might see in a concussion clinic, and different types, new versus established patient. There's a series of references that are provided here for you to look over. There are literally several hundred impact-related resources as it pertains to both evaluation and management of the patient using impact data. Thank you for your attention, and if you have any questions, let us know. We're always available to answer questions related to the use of impact testing and or applicable billing codes. Thank you.
All right, thanks so much, Jim. We do have a couple of questions right away here, so let's get started with those. Our first question: if the provider is only interpreting a concussion test that was administered by another provider, which code would you use?
I would look at one of the, like 96136 or 137, the half hour interpretation, and assuming that the interpretation also involves treatment planning, etc. Or the other option there is to include it as part of the evaluation and management code. It's going to depend on the insurer in that case.
Okay, thanks. And our last question: is impact considered to be a battery of tests?
So that's actually a very good question. We advertise impact now as a neuropsychological battery. The insurer, again, will have to decide whether they consider it a battery or not. In the event they don't consider it a battery, things like the BESS and the VOMs and some brief memory scales or other such tests, usually 3 to 5 minutes in length, will suffice for the multiple measures. So it's, again, really depends on the insurer as to what they consider impact, as to whether it's a battery of tests or an individual test. Our clearance by the FDA is we are a neuropsychological battery.